All right, we didn't have time to review this last time, but now we do. And then we'll skip the review at the end of this one, I'm sure. Okay, so what causes diffuse axonal injury? Shearing forces. What causes those? What are those? Yeah, rotation. Right, so as you rotate around some point, when you're further away from that point, you get displaced further. It stretches axons. It's going to cause you to sever. Why is it that axons are more likely to be injured than, let's say, a cell body? There you go. They're longer, more surface area, sure, right? They're extending over a greater distance. You're just more likely to be damaged at that point. How about excitotoxicity? This is nothing new. If you answered number 4 on exam 2, this is really nothing new to you. Jenna Martin. Oh, you don't have to call me that. Just Jason's fine.
Jason what? Oh.
So what might cause excitotoxicity?
Increased intracranial pressure from, blood. What am I thinking? Blood toxicity could start it. Glutamate toxicity.
Okay, we're getting there.
How in depth do I have
We're getting there.
calcium influxes? How in depth do I need to go right now? Because I really don't.
Okay, so your body's here. We'll get the brain in there in a little bit. That's
Yeah.
all right. It is early. It's only 11. Most of us don't usually get up at this time. Well, anytime you have injury, you want to think inflammation. Okay, maybe you have immune cells coming in, or maybe we just have reactive gliosis. Reactive gliosis is going to impair glutamate buffering. That leads you to your glutamate buildup, glutamate toxicity, impaired potassium uptake. Intracranial pressure is also good to bring up. Everything's mechanically gated to some degree. So if you have an increase in pressure, that's going to push on neurons, and that can physically force open their ion channels. We're not ready for this. Should I just move ahead? I see some yeses. This is your class. I'm just standing in the front. Okay, fine. We'll move ahead. If you have questions on those, please see me. Also see me to pick up your exams. The regrade's going to be due in a week. That date, right? It's on the Google Calendar.
Yeah.
Always check that. Don't listen to me. We did pretty well. The median was an 82. Not bad. Multiple choice scores, I think, have been uploaded. Yeah, I think. I don't know. I think I uploaded them. You tell me. I don't know. It says exam tutor portal. Sounds like something. Okay. Turn this. Forget this top squiggly part. This is now a period. Okay. Spinal cord injury. So we're moving down. Very similar to traumatic brain injury. There's still primary and secondary injuries. I'm going to go over secondary injuries again. See the last lecture. See all the lectures before that. Same stuff. We'll talk about the symptoms and the prevalence of spinal cord injury, and then we'll talk about how the injuries occur and these different syndromes, depending on which parts of the spinal cord get injured. There was one question. So basically, what's the difference between concussion and contusion? Can these be the same thing? And it depends on how you think about the word concussion. If you think of it as just a concussive blow, then sure, it can cause contusion. But if you think about it as the strict definition of it's a blow to the head, or in this case, spinal cord, that causes a momentary disruption in function. So there's not tissue damage, but it gets rattled around. That can lead to mechanical stimulation. That can momentarily disrupt function. But it doesn't lead to tissue damage. If we want to be strict, tissue damage occurs with contusion, and that could be the nervous tissue. It could be the vascular tissue as well. So contusion is more severe than concussion. If you think of concussion as just a blow, though, sure, that could cause. But if you think of it as an injury that doesn't lead to tissue damage, so with that strict definition, concussion is better than contusion or laceration. All right. So when we injure the spinal cord, we're injuring the link between the central nervous system, or more specifically the brain, and the peripheral nervous system. The peripheral nervous system is what communicates with target tissues, so that we can control our body, take a drink, walk around, things like that. The prevalence is far lower than that of traumatic brain injuries, spinal cord injury. Mostly males are going to get spinal cord injuries. We do stupid things. Stupid things can cause spinal cord injuries. The age of onset is increased compared to the 70s. We're living longer. The most common cause, motor vehicle accidents. Falls as well. Falls are still a major risk here, just like they are with TBIs. So very similar in that respect, just far less common than TBI. When we look at the level of injury, and by that I mean severity, not spinal level, incomplete quadriplegia or tetraplegia is about half of the cases. Paraplegia is going to make up about the other half, being half incomplete, half complete, and then the remaining 10% being complete quadriplegia. Depending on the level or the severity of injury, that's going to determine the impact on lifespan. And in general, we see a decrease in lifespan following a spinal cord injury. So here we're looking at the years remaining for a 20-year-old who suffers a spinal cord injury or doesn't. Let's see the no spinal cord injury here. You should have about 60 years left on average. With any spinal cord injury, that drops a bit. And as you see, when we increase the severity of the spinal cord injury, the number of years left decreases. So as we move on up the spine, and when we start to interfere with ventilation, that's when we really see the decrease in life expectancy. Breathing is fairly important, and so when it's compromised, lifespan obviously drops. Aside from respiratory distress, there can also just be a predisposition to infection. There's a couple of reasons why that might occur. Our immune system is regulated by our autonomic nervous system, at least in part. And so when we damage the spinal cord houses many of the preganglionic autonomic neurons. So in the thoracic spine, that's where we have our sympathetic neurons. Any disruption in communication with those neurons or damage to them is going to impair immune function. It's no longer able to stimulate, for example, the spleen here to initiate an immune response. And you do see some alteration in immune function in spinal cord patients. It could also be due to the inability to clear out the airway. So aside from just being unable to breathe, with higher up injuries, anything above C4, you run the risk of damaging input to your phrenic nerve, which innervates the diaphragm. The diaphragm is paralyzed, no more breathing. Breathing can be more difficult when we suffer injury below C4 and in the thoracic spine, because these are going to innervate your musculature in this region. So the abdominal, your intercostal muscles, you guys know more about this than I do. But when those are weakened or paralyzed, your ability to cough becomes perturbed. Without the ability to cough and clear out your airway, you run the risk of fluid buildup. This can predispose the patient to pneumonia, which is another major cause of death in spinal cord injury patients. So it could be infection, sort of widespread sepsis because of this immune dysfunction, or it could just be infection in the lungs because of weakening or paralysis in the intercostals, abdominal muscles. We can determine the level of injury with a form like this. You've seen this before, yes? Yes, you'll be using this? No? Actually, no? Okay, well, you'll see it. So this is a standardized form where you can test sensory function in the dermatomes. More on this next semester and in any of Jordana's classes. So here's a map of the dermatomes. They're not as nice and clean as they are on this, I guess not a fellow here, whatever that is. There's a lot of overlap between your dermatomes, but you can get a rough idea. And so you should have sensory dysfunction at the level of injury and below. Because we're going to be severing tracts here, so it's not just at the site of injury. So higher injuries are going to be far worse for the patient because you're more likely to impair respiratory function and you cause more widespread loss of sensory and motor function. So the highest up in that cervical spine, there's where you have quadra or tetraplegia, weakening or paralysis in all four limbs. Paraplegia is going to have to be lower down. After we pass the cervical spine, so we can spare the upper limbs, so thoracic, lumbar, that's where you're going to have weakening and paralysis just in the lower limbs. And these lesions aren't always complete. You might not have complete paralysis, sometimes it's just weakness. So you'll test your dermatomes. Here's a list of those. And then you'll also test reflexes, motor function. That'll also help you localize the level of injury. So at the level where we have the injury, there you should see lower motor neuron type weakness. So what should we expect for our reflexes there? Stronger or weaker? Weaker, exactly. We damaged the motor neuron that inhibits the muscle. We shouldn't see a response, or we should see a weaker response depending on how severe the injury is. What about below that level? What should we expect for our reflexes? Lower, higher, same. So let's say I have a spinal cord injury right here around the navel, T10. Let's say I then test my patellar reflex. Should I expect it to be a more robust response, or should I expect a weaker patellar reflex? You should expect a more robust reflex. Your lower motor neurons are intact. What's not intact are those upper motor neurons. And we're going to talk about this in more detail later on. So let's oversimplify it for right now. We'll get into how this works next semester. But we should appreciate that part of conscious movement has to do with inhibiting spinal reflexes. The spinal reflexes are there to resist changes in muscle length. That's their job. So that until you tell a muscle to move, it doesn't. So they keep the noise low. They prevent improper movements. So there's a very simple reflex arc. If there's any change in muscle length, that stimulates the spinal reflex that activates the antagonistic muscle to oppose that contraction that took place, unless you want it to happen. If you want a muscle to move, the corticospinal tract is going to inhibit spinal reflexes and stimulate that muscle, so that when the muscle changes length, it doesn't stimulate the spinal reflex. That gets inhibited with our corticospinal tract, and that's why upper motor neuron damage leads to that hyperreflexia. No longer inhibited. There's always some inhibition in your corticospinal tract. There's some tonic inhibition of spinal reflexes. Not enough that they won't occur, but enough that we don't have these pronounced responses. So that if you were to test a reflex, when you change the length of that muscle, you're going to get a very robust spinal reflex. And so spasticity is a common complaint in spinal cord injury patients, along with, of course, the weakness. Pain is a common complaint. You're severing sensory relays. when you lose sensory input, it's not uncommon for pain to then take over, because pain is more distributed than just pure tactile sensation. And then, of course, there's fatigue. It's harder to get around when you can't move part of your body. And then they have disrupted autonomic function as well. And that's because we have more than just somatic nervous system. We also have the autonomic nervous system. A thing that works in the background to make sure that when we stand up, all the blood doesn't just rush out of our head, and when we lay down, all the blood doesn't just rush to our head. So it controls our vasculature, it controls our sweat glands, it controls our immune system, it controls our bowels, bladder, genitals, like that, your gastrointestinal system. And so we have these two opposing branches. In the spinal cord, we have our sympathetic neurons, mostly in the thoracic, but also in the upper lumbar region. And then down in the sacral region, we have parasympathetic neurons. They're also up in the brainstem, but we're not talking about that today. But they are there. When we have a spinal cord injury, anywhere along here, it doesn't matter where, we're going to see anywhere above if we have injury above the level, we're going to have upper motor neuron type weakness in our autonomic nervous system. So it's going to be hyper-reflexive. We'll see an increase in sweating, for example. If we have damage at the level, we'll see lower motor neuron types, so there'll be essentially denervation. So we might have a focal region where we are unable to sweat, and then below that we have excessive sweating. It's fairly important that your sympathetic and parasympathetic nervous systems work together. These need to work in a coordinated manner. And oftentimes, they're going to be controlled by higher up structures, which we can't really see here. But have you ever had to get up and talk in front of people? A little sweaty and nervous? Mm-hmm. Yeah, I do all the time too. That's because of activation of your sympathetic response. So your sympathetic nervous system knows what's going on only because of this sending input from the brain. Spinal cord injuries sever that. Now it's purely reflexive at this point. And this can pose an issue, particularly when it comes time to urinate, defecate, or have sex. These are all going to be controlled by your autonomic nervous system, and you have some control over it. We can hold our piss. We're not just incontinent. So there's some conscious control as well. We'll go over this reflex in more detail next semester. Right now, what we need to appreciate is that there's tonic sympathetic input that inhibits contraction of your detrusor muscle. So your bladder is sort of tonically inhibited from contracting, so it can fill up. And there's tonic excitation of the internal urethral sphincter. So that remains closed, again allowing the bladder to fill up. Tonic sympathetic input keeps us from urinating, so it allows the buildup of urine in the bladder. When the bladder is stretched sufficiently, this is going to stimulate a reflex where we now activate the parasympathetic nervous system that's going to inhibit sympathetic output and then stimulate contraction of the detrusor muscle, causing the emptying of the bladder. This is, of course, under conscious control. We can control our external sphincter there, so we make the choice. And when it's time to go, we open up here, urine flows, that stimulates another reflex that allows this to complete. In spinal cord injury patients, this reflex doesn't always work. If we have higher up injuries above the level of the lumbar and sacral regions here, which is what contains the preganglionic autonomic neurons that control bladder function. Here's our bladder here. So injury above this is going to cause upper motor neuron type weakness. So we should have a spastic bladder. Here it is. Anytime you have the slightest bit of stretch, this spinal reflex gets activated. that tonic inhibition from descending pathways is gone. So the slightest stretch of the bladder causes contraction. But these two branches don't always work together, your sympathetic and parasympathetic. So you might still have contraction of your internal urethra, and that leads to very painful, strong, what we call urge incontinence. So you feel like you have to urinate, even though your bladder is fairly empty. On the other hand, lower injuries are going to cause lower motor neuron type weakness. If they're down in the sacral region, that only affects the parasympathetic nervous system. Sympathetic nervous system is working just fine. Sympathetic is there to allow the buildup of urine within the bladder. So what you get is urge incontinence, or you get overflow incontinence, where the bladder fills, but it's difficult to empty. It's going to require a catheter here. Because we damaged the lower motor neurons in the parasympathetic nervous system, they can't cause relaxation of the internal urethral sphincter. They can't cause contraction of the detrusor muscle, so we can empty our bladder. Obviously, this can impair quality of life. So autonomic dysreflexia certainly adds to the difficulties, aside from the motor weakness or paralysis and the loss of sensory function. More on this later, but we should appreciate that these autonomic reflexes are going to be perturbed. It's not only the conscious movements that are carried out that get lost, but the unconscious sort of automatic reflexive alterations in smooth muscles or your vasculature, cardiac function can be dysregulated as well. The autonomic nervous system is pretty amazing. Okay, do we have any questions? Yes?
This feels like a dumb question, but are there only upper neurons in the spinal cord, no lower motor neurons? Does lower motor neurons innervate like the target tissue? Is that correct?
That is correct. That lower motor neurons innervate the target tissue. The lower motor neurons are going to be housed in the spinal cord.
Right.
So that means that their cell bodies are located in the spinal cord. And we have a couple different types of motor neurons. So they could be the somatic motor neurons, the ones that control your skeletal muscles, that allow you to move as you would like. And then there's the motor neurons in the autonomic nervous system. So upper motor neurons, those are going to be in the brain. They could be in the hypothalamus, if we're talking about those involved in autonomic regulation, or they could be in the motor cortex, and also the sympathetic cortex as well. All right, there's brain, spinal cord, close enough. Upper motor neurons are here. They're going to project downward to encounter some lower motor neuron, and that's going to innervate some target tissue, whatever that may be. Let's say it's the bladder. Okay, you can see this. So if we were to look then in the spinal cord, here's our gray matter, surrounding white matter tracts. If we're talking about, let's say, the sympathetic nervous system, I'm going to add a lateral horn here. So this should be gray. Here's where we find our sympathetic, if it's thoracic, parasympathetic down here in sacral, lower motor neuron. You can think of it as that. Really what we would call it is a preganglionic sympathetic neuron. But there's a descending tract from the brain that's going to innervate that lower motor neuron. If it's in the somatic nervous system, those are housed in the anterior horns. There would be a descending tract. Let's see, we'll call it a limb. We're going to go down the lateral corticospinal tract, which we'll see in just a moment. Here's our upper motor neuron innervating the lower motor neuron. This is going to head out the ventral root and innervate some muscle. So the lower motor neurons are in the spinal cord. That's where their cell bodies are. Their axons project out of the spinal cord to innervate the body. Upper motor neurons have their cell body in the brain, but their axon forces through the brain into the spinal cord. Soma up here, axon running down through the spinal cord. For a lower motor neuron, soma in the spinal cord, axon exiting to form a peripheral nerve. Make sense? And there's no such thing as a dumb question, or so they say. That one was not. Any others? All right, well, click ahead and get started on those questions. Thank you.
What?
A little too much discussion.
You routing back here?
Oh.
Yeah.
So I would take the risk with, I guess. Yeah. I apologize.
All right, sounds like we're ready to go ahead. Anyone need more time? We okay here? Okay. Stephanie Snodgrass. Common causes of spinal cord injuries.
Motor vehicle accidents, falls, violence, sports injuries, or
All right. There we go. And we'll see why a motor vehicle accident might cause a spinal cord injury. How are we going to determine the site of injury? Callie Mathers, not Kaylee.
You assess the dermatome and tendon reflexes to localize the site, and if they're paraplegic
region, then it's gonna affect the lower the trunk and the limbs, and the part of the region affects all the limbs and the trunk.
Fantastic. Looking for dermatomes. That's a band of skin innervated by sensory nerves, and then we're looking for tendon reflexes. Very good. All right. Let's see. Change in life expectancy. How does that relate to that site of injury? Let's say we have, I don't know, say higher up. L.
Yes.
Okay. Confirm
So
that
if it's an injury higher up in like the spine, if it's C3, 4, or 5, we probably need a ventilator. And can't breathe, not alive.
Mm-hmm.
So, and then the thoracic spine has the, if it's like weakened or paralyzed, then the abdominal or intercostal muscles may not function, and then with a clear airway, and then also like immune function may be decreased because it's sympathetic.
Okay, great. You've jumped ahead here. Wonderful. Okay. I think we're pretty good there. Anything you want to review? I feel all right about it. Okay, good. There's two of us. All right. Just like every other injury, location, location, location. And real estate? Is it real estate? So, in a motor vehicle accident, it's not uncommon for the head to get thrown around. And if your chin were to encounter that steering wheel, it can lead to the excessive flexion. It's going to create, potentially, this Hangman's fracture. The excessive flexion of the spinal cord, whether it be up in the cervical region or down lower, accounts for about half of the injuries. When we have that flexion, what we run the risk of is fracturing our vertebrae. Could be those pedicles that are going to hold your body and your vertebral arches together so you have a rigid structure. When those sever, then they're kind of free to move around. Now, it's not uncommon for a patient to walk in with this Hangman's fracture. And as a matter of fact, it's named after those judicial hangings that were carried out. But most people didn't actually suffer a Hangman's fracture from those. Very, very small number did. So here we can see, right here, C2. You can see this fracture right there. Not excessive displacement, though. See that here. This is where you're going to run into more issues. This patient probably was not walking in to get treatment. Being wheeled in. Here we can see that anterior displacement there. That's going to be an issue. Any enlargement or shifting, no matter what causes it, whether it be arthritis, tumor growth, just the natural wear and tear on the spine, that can allow shifting of vertebrae, and that can compress the spinal cord. It can also compress or damage the arteries that run in the vertebral column. Alterations in blood flow can be devastating to the nervous system. This is still true. Now, the reason that spinal cord injuries are more, the reason spinal cord injuries create more long-lived deficits than, let's say, a peripheral nerve injury has to do with the impaired ability for axons to grow in the central nervous system. After you develop, once you leave mom, your central nervous system is not permissive to axon growth. It's only permissive very early on to establish these sort of characteristic connections between different brain regions, and then after that, there's a change in the environment that prevents axon growth. You don't want your central nervous system to dramatically change once you've set it up and you start putting information in there. Learning language, learning how to control your body, things of that nature. You want those pathways to remain fairly stable. So the central nervous system going to prevent axon regrowth. This is great as long as everything goes well, but in the case of injury, it sucks. Peripheral nerves can regenerate to some degree. Depending on the severity of the injury, you might have complete recovery. Spinal cord injuries are going to create long-lived deficits. There's reduced axonal growth in the central nervous system. And this is a classic experiment. These data are older than I am. What they did here was lay down portions of the optic nerve and the sciatic nerve, central nervous system, peripheral nervous system. Different glia, oligodendrocytes over here, Schwann cells over here. Then they lay down a little bit of silicone grease here to isolate the region where our sciatic nerve and optic nerve is growing. And they threw some neurons in the middle. Let them grow. They look to see how well do the axons migrate through this sciatic nerve or the optic nerve. When they wait 2 to 3 weeks and have a look, you can see axons emerging from that sciatic nerve. Invariably, axons grew through the sciatic nerve. Here's the end of it. Here's the severed end of the sciatic nerve. So they were growing down there somewhere. And after a couple weeks, you can see axons emerging at the end. Optic nerve. Here's the end of it. It's kind of playing out there a little bit. No axons. Nothing came out of the optic nerve. Axons never grew into or exited the optic nerve. Oligodendrocytes are all along this optic nerve. Sciatic nerve, Schwann cells. Schwann cells are permissive to axon growth. Oligodendrocytes are not. Now, since my birth and the publication of these data, we've identified a few myelin proteins that interact with the axon and inhibit outgrowth. So the myelin in the central nervous system is different from that in the peripheral nervous system. And that's why a spinal cord injury is going to have very poor recovery. Those myelinating glia there that line those severed tracts prevent axon growth. On the other hand, if you injure a peripheral nerve, axons can regrow. Peripheral nerves have Schwann cells. They make different myelin. That myelin does not inhibit axon growth. Clearly, it's permissive to axon growth, as we can see here. And then there's also an alteration in the axons themselves. They respond to the injury too. At the site of injury, they're going to retract and enter that glial scar. We still get reactive astrocytes with this injury, just like every other injury. Those reactive astrocytes interact with the axon and modify its ability to exit the glial scar. So the axons essentially get trapped there. And they'll form these little dystrophic whorls that can sometimes cause pretty severe pain. And they'll live there for decades. So it could be there's differences in the glia. Oligodendrocytes are not permissive to axon growth. Schwann cells are. And then the axons themselves change. So even if the oligodendrocytes didn't inhibit them, they wouldn't be able to leave anyway. So that's why spinal cord injuries are going to have limited recovery. Now let's get a brief overview of the tracts. We'll go through these in greater detail next semester, but we should just have some idea of where they're laid out so that we can understand how different types of injuries create different motor and sensory deficits. Red is motor, descending. Blue is sensory, ascending. So we're heading up when we're blue and down in the red. There's really 3 tracts that you need to know as a clinician because they're the ones involved with conscious control or perception. This is what your patients are going to be aware of. As great as the spinal cerebellar tracts are, you don't really need to know those. What you do need to know would be the cortical spinal tract. There's a couple of those. Here's our lateral cortical spinal tract. and here's our anterior spinal tract. These are going to more control the limbs, so fairly important. Anterior is going to control more of the trunk. So there's an arrangement here that makes sense. There is a method to the madness. They are organized based on which part of the spinal cord they're going to control. So there's a superior to inferior organization, cervical, thoracic, lumbar, sacral, usually a little more on the outside. We'll see that again in a bit. There's what we call extrapyramidal tracts, so that's everything else. Non-conscious motor output. That could include the autonomic nervous system, in the case of the not shown hypothalamospinal tract, which should be somewhere around here. And then there are other descending tracts from the brainstem that allow sort of automatic reflexive movements. So you can just stand up and you don't have to worry about your balance or anything like that. They're pretty nifty. But we don't have conscious control over them. These two sensory tracts are very important. The posterior columns are in the posterior portion of the spinal cord. They run up like columns, hence the name. These are involved with non-painful sensation. So just normal touch, vibration. The spinal thalamic tract, which is a part of the anterolateral system here. So there's our spinal thalamic tract. This conveys pain and temperature sensation. It's important to note that the spinothalamic tract crosses within the spinal cord. All the other tracts cross up in the brainstem at the level of the medulla or slightly above. And that is going to help us whenever we talk about a hemichord lesion. For the most part, tactile sensation in the back. Sure, you got your lateral part of the spinal tract back there too. But we actually consider the first 2/3 to be anterior. More anterior regions, you can see a lot more motor, including that anterior part of the spinal tract. And then the anterolateral system. So pain, temperature, and motor more in the front, sensation more in the back, particularly in the middle. Okay. Transverse cord. So complete severance. That's going to disrupt everything. That's pretty straightforward. So if we have a T10 or 11 lesion here, everything below. No motor function, no sensation. Pretty straightforward. The key is over here. You can see the lesion on this little image. These are going to be consistent in the slides. Blue, that's going to be the posterior columns, so non-painful tactile sensation. Green will be the pain and temperature, so that's your spinal thalamic tract. And then red, motor, that's your cord spinal tract. So at that level, everything's lost. A hemichord lesion, or the Brown-Séquard syndrome, this is where half of the cord is damaged. And this is why it's important to note that the spinal thalamic tract crosses within the spinal cord. So at the level of the lesion, which is right here, you're going to get below that ipsilateral, so on the same side, your motor weakness, so you're going to affect the motor pathways, and your non-painful sensory loss. Pain and temperature are going to be lost on the contralateral side because these have crossed over and are running up the spinal cord on the opposite side. So both sides are still affected, but not at all in the same way. This is usually going to be caused by a stab wound. It's hard to only hit half the cord. So backstabs are what's going to cause this hemichord lesion. More common. A central cord lesion is going to be caused either by There could be demyelination that can cause this. It can also be from a tumor within the spine or from a hemorrhage. So an intramedullary hemorrhage within the spinal cord tissue is going to cause death of nervous tissue. That's going to get filled in with cerebrospinal fluid. It's going to create that syrinx in a condition called syringomyelia. Here we can see this cyst, the CSF-filled cyst. This is a T2 weighted MRI, so the fluid is going to appear bright. Here it is. We shouldn't have this. Our spinal cord should be filled with nervous tissue, but we can see an area where we actually have this fluid-filled cyst. And this can pose a problem for the surrounding nervous tissue as it balloons. As it develops and enlarges, that's going to compress the surrounding tissue and cause further degeneration of the spinal cord. Depending on the size of the lesion, we're going to get different types of motor and sensory loss. And it's very, very focal. You might get this cape-like distribution, but larger central cord lesions, that's going to really affect much greater areas of the body. It depends on the level where it's going to start. Here they're putting it very high. It doesn't have to be that high. It could be further down. What we often see is sacral sparing, because those fibers run more along the outside of the spinal cord, because there's an organization. It's not just pure madness here. Like cervical, thoracic, lumbar, sacral. So until we have a central cord lesion that essentially becomes transverse, you're going to have sacral sparing. So the anal and genital regions are going to have preserved function. A little easier to understand than that, I think, is the anterior and posterior cord syndromes. A little more rare. These are going to be caused by vascular insults or tumor growth, things like that. They're going to compress the posterior or anterior regions of the spinal cord. So the anterior cord syndrome, this is going to disrupt the corticospinal tracts as well as the spinal thalamic tract. So here you're going to see motor and then pain and temperature loss. Posterior cord syndrome is going to hit the posterior columns. Let the names work for you. And so in the posterior cord, there we're going to see just loss of non-painful sensation. Depending on the level, of course, that's going to determine where it starts. It doesn't have to start in the neck. Does that make sense? I got some yeses. That's good. Anything that we should go over? Any questions? Yes?
So, what would cause an anterior posterior cord syndrome?
So it could be either a blockage or a rupturing of the vasculature that runs in the spinal cord. So there's anterior and posterior vessels, and they're going to innervate really these regions. So the anterior arteries are going to innervate the anterior kind of two-thirds. So you essentially get a stroke or hemorrhage in the anterior cord. That's going to cause anterior cord syndrome. Same as the posterior. Or it could be tumor growth. As the tumor grows and it compresses that tissue, that can lead to impaired sensation or motor function, depending on what we're compressing. No other questions? All right, cool. I have some. We don't have the minutes for it, not surprisingly. So we'll talk about them later. If you have any questions on this, come see me. If not, come see me for your exam.